Thanks, David. It's a great pleasure to be able to be here. I also am humbled to be able to follow Dr. Cotton and Dr. Saar, and we'll try to give you a little bit of the history of total pancreatectomy with islet autotransplantation. And it's something that I really learned as a pancreatic surgeon when I moved to the University of Cincinnati in 2001 and got to work with Horatio Relo and his team, and then working at the University of Chicago with our current team, Andres Gelrud and Piotr Witkowski. And I've been very fortunate to be able to be involved in some of this work. Total pancreatectomy with islet autotransplantation for chronic pancreatitis has now become something that a number of centers are doing, and we have ability to treat patients like this, a 31-year-old mother of 3 with 3 years of chronic pancreatitis, severe recurrent pain, no other good therapies, a strong history of pancreatic cancer in her family, small duct disease, no other conventional surgical options, undergoes a total pancreatectomy with a harvest of 265,000 islet equivalents, and is able to have pain relief. And in this instance, at least in short-term follow-up, no need for insulin, no post-pancreatectomy diabetes. And it's rather remarkable in the appropriate patient to see how well they can do. But what is the history behind this? And I guess the history of total pancreatectomy with islet autotransplantation has to consider the history of using total pancreatectomy, which was initially performed for cancer before it was performed for chronic pancreatitis. A bit of the history of whole organ pancreas transplantation, which I'm really not going to talk much about, and I'm not really qualified to talk about. The history of islet transplantation, allotransplantation in particular, and then autotransplantation, the initial reports that were alluded to by Mike, leading us up to the modern series of total pancreatectomy with islet autotransplantation, and the work that's going to come from members of the audience that we're going to hear over the course of the next 2.5 days, and at hopefully a number of conferences and working group sessions to come. So, it's pretty dramatic to remove the end organ to solve a pathology, because there's usually side effects to that. It's great to remove the primary disease. But, for example, this was noted by Charles Dickens describing the guillotine in A Tale of Two Cities. He described the use of the guillotine as the best cure for headache. It infallibly prevented the hair from turning gray. And so it can be very effective, but there are side effects. So what was the story behind this? Well, the first total pancreatectomy that was appeared in print was reported in 1943 by Rockey. But he states that there, in fact, was a case that was reported earlier by Bill Roth, although was not documented. In Dr. Rockey's description of removing the entire pancreas for carcinoma, he did a total pancreatectomy, 1943. This is the drawing from the Annals of Surgery article. You can see the total pancreatectomy has been done there. There is a loop cholecystogeginostomy and end-to-side gastrojeginostomy as the reconstruction. That was the initial procedure that was performed, but it really was not used widely for chronic pancreatitis as a therapy for some of the reasons that Dr. Saar discussed. It clearly was only going to be used as a last resort option for patients who had marked destruction of the gland. It was really first reported for chronic pancreatitis by Waugh and by Whipple. The physiology of patients who had undergone total pancreatectomy was worked out by Paul Jordan in 1957, and even as late as the work of Ken Warren at the Leahy Clinic in 1966, with a very large series of patients who were operated on for chronic pancreatitis. It was only used in 8 out of over 500 operations for chronic pancreatitis. So it really was a last resort operation. And the common themes that were noted for patients in the 60s who underwent total pancreatectomy for chronic pancreatitis was the trouble of insulin hypersensitivity, which was occasionally severe, very difficult to control with exogenous insulin in at least 15%, patients with frequent jejunal ulceration, difficulties in nutritional management, and notably, still the idea that even after you had the guillotine, you still had the headache. There was still persistent pain in at least 25% of patients who underwent total pancreatectomy, and that is a figure that still persists today, has a lot for us to do with patient selection and understanding neural pathways of the perception of pain. Now, pancreas transplantation, from an experimental standpoint, goes back to the pioneering work of Miriam Minkowski in the 1890s, who demonstrated that pancreatectomized dogs developed diabetes. In Paris, as part of investigations into the study of the function of the pancreas and its relationship to diabetes, actually the first autotransplantations of the pancreas were done, but it was not thought of as in a therapeutic sense. It was thought of to understand the physiology of the pancreas. And although between the 1920s and 1960s there were various and scattered investigations of pancreatic autografting, there was really nothing focused in terms of developing that as a true therapy. Interestingly, the first allotransplantation of islets was performed by Whipple in 1935 when he took fragments of an insulinoma and gave it to other diabetic patients as an allotransplant. Of course, the grafts didn't take. He transplanted them to the forearm, and they didn't take. Now, so in thinking about the history, and I'm not going to go into the details, it's worth, and by the way, if you haven't seen John Howard's textbook on the history of the pancreas, it's really a remarkable book where I got some of this information. The history of allotransplantation versus autotransplantation obviously bifurcates to some extent, and then the history of whole organ transplantation of the pancreas versus isolated islets also bifurcates. And I'm not really going to talk anything about allotransplantation. It's certainly not at all my area of expertise. But islet transplantation as experimental therapy started as a suggestion by Paul Niehans of Switzerland, who suggested that digesting the pancreas to isolate islets might be a therapeutic option, and did some experimental studies by report, but he never in fact published his data. But he's attributed with generating the concept. The efforts in the 1960s were focused on the technical aspects of isolating islets by Moskowski doing collagenase digestion of exocrine tissue, the work by Lacey in 1967 of mechanical mincing of the pancreas combined with collagenase to isolate out islets, the work by, and I don't, have not met or did not know these individuals, but Dr. Yunozaus, I won't be able to say that, islets transplanted into the peritoneal cavity of rats, showing temporary improvement in hyperglycemia. The classic, really landmark paper was presented at the Society of University Surgeons meeting in 1972 by Ballinger and Lacey, which showed the long-term correction of hyperglycemia by islet cell transplantation in diabetic rats. The work of Kemp and Merkovich in 73 and 76 talked about the route of islet transplantation, initially intraportal infusion, but also experimental efforts to use intrasplenic. This led us to the work in the 1970s, really by the pioneering group at Minnesota, and we owe tremendous debt to these two individuals for their pioneering work. Dr. Najarian and Dave Sutherland certainly take so much credit for getting this field to where it is today. And their initial report, published in 1977, involved human islet autotransplantation in a patient who had a 95% a subtotal pancreatectomy and near total pancreatectomy, who interestingly was able to be made insulin independent but had persistent abdominal pain after total pancreatectomy. Now, the early clinical series from Minnesota and from Hopkins used intraportal rather than intrasplenic infusion, which still hasn't been applied much in humans. And in the early series, it's important to note that it was a near total pancreatectomy, not a total pancreatectomy, as a duodenum preserving approach. And I think we'll be hearing more about some of the technical aspects of the pancreatectomy later at this meeting. The first series was presented at the American Surgical Association in 1980 of total or near total pancreatectomy with islet autotransplantation for treatment of chronic pancreatitis from the Minnesota group. 10 patients that were treated between 1977 and 1980, most of them who underwent this duodenum preserving near total pancreatectomy. There was one postoperative death. Interestingly, 2 duodenal strictures from the subtotal pancreatectomy, and there were issues with rise in portal pressure from the infusion of unpurified islet preparation. Again, the results were good, but about 20 to 30% of patients in these early series still had persistent pain, although many could be weaned from narcotics. And 3 of those original 10 patients were insulin independent in 3-year follow-up. Now, a similar series with very similar findings was reported the same year by Cameron and Zeidema. 8 patients, 1 postoperative mortality, but in their series, only 3 of 7 experienced complete pain relief. So this theme of pain persistence despite complete removal of the end organ persisted. And in the early going, in the 1970s, 1980s, a number of adverse events were reported in these patients, such as this report from Hopkins showing disseminated intravascular coagulation with portal hypertension. And for many other reasons, the procedure largely fell out of favor. Now, the early challenges included, as I mentioned, duodenal stricture and duodenal necrosis with near total pancreatectomy, the portal hypertension and DIC that could happen following islet infusion, and this problem of persistent pain, making it not really the panacea for the relief of pain that one might otherwise imagine. And there were a number of challenges with islet yield and preservation, and we have some of the world's experts who are going to tell us about the future and current state of the art for this. But in the beginning, the method of islet preservation consisted basically of cold Hank solution, just basically a buffered saline solution, followed by mincing of the pancreas and a collagenase digestion. While the preservation of islets was improved with the use of UW solution, there continued to be challenges in high variability in the collagenase preparations that were used. The landmark paper of 1988, published in the Journal of the American Diabetes Association by Camillo Ricordi, really set the standard for how islet isolation is performed today, and was an event that really, I think, re-stimulated interest in applying this. It involved intraductal injection of collagenase, the use of a more standardized blend of enzyme called liberase, and the development of an automated separation and purification system to improve islet yield. The modern series of total pancreatectomy with islet autotransplantation came out in the late 90s and the first part of the current century, largely from the group at Minneapolis and to a lesser extent from our program in Cincinnati and the program in Leicester. In more recent years, other centers have come on board. The Birmingham group, South Carolina group, and others are starting to report their results. There have been well over 300 patients reported in the literature, and probably many more that have had the procedure performed. Amazingly, the experience of the 1960s, 1970s, and 1980s continues today with the fact that pain relief is not consistent after total pancreatectomy, and pain relief in narcotic independence is at best 80% and often worse than that. About 25 to 40% of patients are insulin independent in the first year, with a slow drop-off in insulin function over time. So the modern series are impressive, but notably patient selection criteria are highly variable. It's generally agreed that this is a therapy that has applicability for patients with small duct disease, for appropriately selected patients with hereditary syndromes who have failed prior surgical therapy, whether there is something called minimal change disease, which should be approached with total pancreatectomy with islets, is highly controversial but has been applied. Generally, it's felt that contraindications include pre-existing diabetes, prior pancreatic duct conduct decompressive procedures as a relative contraindication, and various other contraindications as well, including psychosocial maladaptation. So we have many future challenges bringing us to the present day, and some of these issues will be addressed over the course of the next 2.5 days, and really needs a lot of our focus. So challenges regarding patient selection and standardized reporting of outcomes, understanding truly the cost-benefit value proposition for this approach, the comparative effectiveness with standard therapy, the use of the total pancreatectomy with islet autotransplantation for expanding indications for use in pediatric populations or for patients with pre-malignant disease, the optimal timing of when this should be applied, the technique of pancreatectomy, methods to improve islet yield, preservation, purification, and survival, the issue of the value of remote processing, or whether the liver is the only appropriate site to be transplanting in humans. So many questions remain, and we'll look forward to hearing some of the answers and current thinking on this over the course of the next few days. So again, I want to thank David for organizing such a wonderful symposium, and look forward to a few more days of vigorous discussion and debate. Thanks very much.